Now coming to central nervous system tuberculosis, that is a very important part, one of the very important, most of the time we get in the our clinical scenario in the ward also. TB meningitis is a very common presentation we see. So when to suspect, the presentation is, we can see fever is one presentation, and here we have seen the duration of 5 days or more. So in this patient, in CNS tuberculosis patient, the low fever of shorter duration of less than a week, you can say, is also taken into consideration, because since we know that in tuberculosis the fever is usually low grade, and that is for more than 2 weeks or to 3 weeks. But in case of CNS tuberculosis, we have to suspect early. Why so? Because we have to diagnose this patient early so that we can prevent the serious complications of CNS tuberculosis. Alright, so delay in diagnosis should not be there. So with fever, the patient can have headache and vomiting. There may be altered sensorium. They can present with cannular palsies. They can present with a hemiparesis or any limb weakness. They can present with neck stiffness or seizures, and also they may have constitutional symptoms as we see in the patient with tuberculosis. And you have to also see that there is active TB elsewhere. By doing a chest X-ray, you can also do ultrasound abdomen to look for the lymph node anywhere in the abdomen, and classically necrotic lymph node is usually seen in case of tuberculosis elsewhere in the body. Alright, past history of TB or ATT is very important. If somebody was treated for the past for tuberculosis, for pulmonary tuberculosis or extrapulmonary in case of other side, so that is a very important risk factor. Being reactivation in such patient, and contact with a TB patient, that is also a risk factor. HIV positive status, low socio-economic status, and if patient is having to high endemic area, meaning our India is also in a high endemic zone. So how to do a diagnostic confirmation, how to do a workup? We do a routine blood workup, chest X-ray, PA view, chest X-ray. If patient is not possible to do a chest X-ray, PA, if the patient is very sick, we can do a bedside X-ray, epifilm also. So to see the lesion in the lung sometimes. So we can get some old heat lesion, fibrotic lesion, or sometimes we can also see the active tuberculosis by doing the chest X-ray. Okay, that will also support our diagnosis. We can do ultrasound abdomen also to look for the any abdominal lymphadenopathy. Montauk test also we can do, that is an optional test. NCCT or CCT head, that is a preferred as initial investigation. So better CCT head should be done, and is a preferred initial investigation. MRI remains an optional. We can do MRI brain sometime if there is a diagnosis difficulty remains from the other similar diseases. Alright, and LPCSF is mandatory. You have to do a diagnostic lumbar puncture and analysis of your CSF fluid, but it's better to perform a CT scan before CSF in presence of papilledema or focal deficit, because we know that if there is a raised intercalated tension, doing LP in such patient can be serious and can lead to your brain herniation, and there is a chance that brain can herniate and that can cause cardiovascular collapse and also serious consequences. So better to do a CT scan and then you can do LPCSF. So important point is to remember that raised ICT is not absolute contraindication of lumbar puncture. You can do lumbar puncture in those situations also, but that lumbar puncture is guarded lumbar puncture in those situations, with a close monitoring if needed. Okay, so that is very important part. And treatment remains, here we can see it is a 12-month course, 12 months that can be extended up to maximum of 18 months, and that treatment remains 2 months of HRZE, or sometimes if patient is very sick, seriously ill, you can give him streptomycin in place of ethambutol. So regime becomes 2 months of HRZS and then 10 months of HRE. So this is the proposed regime as of now, but in the future we can see this regime, that is 2 months of HRZS and 10 months of HRZ. This recommendation has sent to the NTEP to modify the regime. Here we can see why ethambutol is eliminated in this regime, because ethambutol, we know that it can cause serious ocular toxicity, and if patient is seriously ill, patient is unconscious, disoriented, and we have diagnosed him of TB meningitis, and we have started patient on 2 months of HRZD, and after that patient regain consciousness, we find out sometime that patient has lost his vision. That was not sometime properly assessed. Alright, so that is why, because of the serious ocular toxicity, in the coming time this ethambutol might be omitted from the standard regime, and then we have to follow this one. So as of now, currently we are following this one. If the patient is really very sick, we omit ethambutol with streptomycin, and the CP phase you can continue with ethambutol for 10 months, and that can be extended to 18 months depending on the clinical response. Alright, steroids, yes, definitely there is a role of oral IV steroid sometime. So mainly there is first we do IV steroid. If patient is very sick, dose remains your 0.4 mg per kg of your dexamethasone, and that is to be tapered over another 6 to 8 weeks. Alright. So important thing here is sometime you can see surgical interventions may be needed in some cases of hydrocephalus to establish a VP shunt so that the pressure, the raised ICD can be taken care of. Alright. So this is how CNS tuberculosis is managed.